Welcome to our second breakout session here. We have Dr. Michael Margolis with us. Dr. Margolis graduated from the University of Texas Dental School. Where'd you lose your accent?
I never grew up in Texas. Oh. I'm a Yankee, so.
Darn, I started to say they really converted you there.
I can talk like y'all do.
We'll keep him as an honorary Texan here, and earned his Doctor of Integrative Medicine at Capital University. Michael helped start the Institute of Nutritional Dentistry and is a past president of the International Academy of Biological Dentistry. The International Academy of Oral Medicine and Toxicology is a member, and also the Holistic Dental Association. And now he practices in Mesa, Arizona. So let's welcome him back to Texas here, Dr. Michael Margolis.
Thank you very much, Johnny. Our AGD disclaimer: I do not have any financial interest of a product in my talk or with any companies offering grant monies for continuing education, dental, or medical programming. Well, good afternoon. I went to school out here in San Antonio. This is like my second whole trip back, and I remembered two things. Everybody had an allergy this time of year. They sneeze like because the wind comes up and the ragweed hits you, and you sweat. It's just really hot. So I have to take off the jacket. There's two parts to this. We're going to be talking about diagnosing and putting things together and why do I do this. And second, we're going to show a number of surgeries when we come back. So we're going to go ahead, and I want to talk about our organization positional paper on human jawbone necrosis. On March 2, 2008, the IAOMT presented a 5-page paper, and the International Academy of Oral Medical Medicine and Toxicology founded that the belief that science should be the basis upon which all diagnosis and treatment modalities should be based. The IAOMT urges that dental schools, medical, and research communities to continue applying the medical or the scientific method in order to diagnose, treat, educate, and ultimately prevent the occurrence of human jaw osteonecrosis. The controversy today is this. First, what is a NECO lesion? Because you heard me say human jaw osteonecrosis. And then, second, how does a practitioner identify, diagnosis, a lesion of a human jawbone? Clinically, how do these lesions affect our patient's health? And fourth, what are the appropriate modalities of treatment for this condition? And I hope to hit all these. And if you have a question, just speak up. But if you want to get some scientific basis, if you look at the oral maxillofacial centers, Dr. Jerry Boco now is at the University of Texas down the road in Houston. He's the head of diagnostic studies. And he's done a whole thing. In fact, he's the one that named NECO, necrosis, osteonecrosis. And he has these websites. They're great to look at. And oral surgeons all over the world, he sends out little quizzes for them. And they take a look at this and they say, okay, how do we do this? And how do we take the test? And he gives options. And from there, they take a test. And they've got about a 98 to 100% concurrence on the history and the slides. So he's worked to get things going. So now we've got to solve this mystery. And this is how we're going to do it.
Los Angeles, California. Some people rob for pleasure. Some rob because it's there. You never know. My name's Friday. I'm a cop. I was working the day watch out of robbery when I got a call from the Acme School Bell Company. There'd been a robbery. There's been a robbery. Yes, sir? What was it? My clampers. Your clampers. Yeah, you know those things inside the bell that makes them clang? The clangers. That's right, we call them clampers in the business. A clapper caper. What's that? Nothing, sir. Now, can I have the facts? What kind of clappers were stolen on this caper?
They were copper clappers.
And where were they kept?
In the closet.
Uh-huh. You have any ideas who might have taken the copper clappers from the closet?
Well, just one. I fired a man. He swore he'd get even.
What was his name?
Claude Cooper.
You think he...
That's right. I think Claude Cooper copped my copper clappers. Kept in the closet.
You know where this Claude Cooper is from?
Yeah. Cleveland.
That figures. That figures.
What makes it worse, they were clean.
Clean copper clappers.
That's right.
Why do you think Cleveland's Claude Cooper would cop your clean copper clappers kept in your closet?
Only one reason.
What's that?
He's a kleptomaniac.
Who first discovered the copper clappers were copped?
My cleaning woman. Clara Clifford.
That figures. Now let me see if I got the facts straight here. Cleaning woman Clara Clifford discovered your clean copper clappers kept in a closet were copped by Claude Cooper, the kleptomaniac from Cleveland. Now, is that about it?
One other thing.
What's that?
If I ever catch kleptomaniac Claude Cooper from Cleveland who copped my clean copper clappers from kept in the closet,
Yes?
I'll clobber him.
I like to do this before I get started to talk about Nikos because I like to be able to laugh once in a while. Ischemic bone disease, what is it? These are Jerry Boco's slides. What you look at, it's like an infection, but it's not a disease in its own right. It's a generic process. It's a local reaction to a variety of systemic or local factors, triggering events which reduce nutrition and blood flow to the bone marrow. How many people today still use epinephrine in their anesthetics? Anybody? I'll tell you it's a big no-no because I believe that it causes teeth to die and bones to die because as you're traumatizing those teeth, you're cutting off their blood supply, their oxygen, and inability to maintain the stress that you've just put it under. And all the surgeries that you'll see later that I do, I give 2 or 3, you'll see there's no epinephrine used in any of them. It may be an abrupt or gradual onset. It may become self-perpetuating. It can be bilateral, multifocal. So this is what a bone looks like. You can see patterns of ischemic bone even in a healthy, normal bone. Over here, you're going to see that there's normal cancellous bone. Up here, you're going to see where the nerve is. And down there, all of a sudden, you start seeing probably considered normal, but it's a small cavitation. It's a small cavity. This is a big cavity. It's multicystic, discolored, mushy posterior mandible in a patient, typical facial neuralgia pain. When Jerry was talking about one of these patients, this is what it looks like on a radiograph. They did this as an autopsy on a patient who had committed suicide. And his wife walked in while he was giving the presentation. Now, if anybody knows Jerry Boco, he's the kindest person in the world. And his heart just dropped because he's giving the clinical reasons. She came up and gave him a hug after the talk and said, at least I know why the man I loved killed himself. Incurable pain. Disease is characteristically hard to see on radiographs. This is why. Because on a radiograph, you must lose 60% of the density of the bone before it even shows up. Cavitation is not the disease. It is the result of the disease. And once you peel back the tissue, push in or cut away the bone, depending upon where you're at, you fall into a hole. And you can see where the alveolar nerve would be. It's not uncommon to pick that up. A hollow subcortical space. And where's this found? Well, Jerry has a unique history. He went through oral pathology and was accepted at Mayo Clinic in a general pathology. And when they were doing pathology on a hip and found necrotic bone there, he says, I've seen this before. And it was slides of the human jawbone. And he went ahead and he set the slides up for his mentors, and he numbered them. And they all said, well, that was hip ischemic osteonecrotic disease. He says, there's one problem. It came from the jaw. These are all the areas of the body, and they're named for the location as much as the disease. Why does it happen? At the ends of the long bones, more susceptible, where blood is furthest from the heart. Ends are where the most turgid blood flow occurs. So it has to come up, turn around, and come back. Periosteal vessels supply outer 1/3 early life, and only 1/10 later, because as the bone develops, they become smaller. And as your blood gets full of gook, there it gets caught, and you get things called plaque. Therefore, the increased susceptibility increases with age, especially beneath the cortex. And then you have the jaw equivalents. If you take a look at the jaw, come on, Mr. Jaw, here we go. You have in the mandible, maxillary, third molar of the mandible, and mandibular ramus here. And caution, you know, if you take a look at an x-ray where you have a cavity, always, when you go in, the cavity is always larger than what you see on an x-ray. It's the same thing with the jawbone. So the dotted line comes here, and you go out there, and you see that. And the cortical access is where you're going to come in. Now, what's really cool is when you take back the tissue and you open it up, you sit back, and I tell everybody I have a cigarette, I don't smoke, but then what you'll see are little blood spots come up to the surface. That is the roof of the cavitation. So there was a controversy in oral maxillary surgery, and in the magazine there was one part one, that Jerry Boco and Robert McMahon, who is an oral surgeon in Indiana, presented a history of the disease, and they took many different forms from phospheus jaw in the 1859s from miners who suffered from it. It was a chemotherapy agent that destroyed the jaw, and now we got bisphosphonates. Had a patient in last week. She told me she wanted me to pull all her teeth, and she was in tremendous pain, had an infection of the jaw, and we asked her one question: how long have you been on bisphosphonates? And I sent her to an oral surgeon. Don't touch them. If a patient has had bisphosphonate, Fosamax, Bonevia, send them to an oral surgeon. You don't need that headache, especially if you're doing a cavitation, because your state boards will go all over you. Now, I'll tell you how to stay away from problems with state boards. That's easy. A review of histological evidence along with scientific information, literary evidence supporting the fact of ischemic osteonecrosis is not so much a disease in its own right as is a natural consequence of a wide variety of systemic and focal factors capable of compromising marrow-bone flow. It's a blood problem. Your blood's not working, the bone dies. It's ischemic osteonecrosis. Don't use the word cavitation. Even though G.V. Black used it in his writings, it's ischemic osteonecrosis. Now another doctor comes in here. He is a PhD oral surgeon, challenging neuralgia-induced cavitational osteonecrosis concept. And he presents a review of literary publications trying to discredit NICO, because he said not all the patients had atypical pain. 80% of my patients don't have pain from the NICO lesion. They have ill health from other parts of their body. And I'll show you how to find that. But a rose is a rose by any other name. And this was found in the Journal of Oral Maxillofacial Surgery. This was part 2 of that controversy. So how do we handle insurance companies? Well, let's face it. They have a problem with their memory. So this is what I send them. It is a nice little bottle of Phillips of milk of amnesia. So to recognize NICO, you have to look at radiographic evidence, Pano, 3D being cone technology, cavitat studies, ultrasounds. We're doing probably 5 to 7 cavitats a week on people that come to us. And there are other different types. In fact, Johnny came up to me earlier today and showed me a thermogram on somebody. And you know, if you look at the New England Journal of Medicine, they'll tell you that the mammograms are basically ineffective. And yet, take a look at the income that they produce throughout the United States today. And a thermogram is much, much better. And here you can take a look, and there are hidden shadows. Because in dental school, this was normal. Of course, if you look here and see that, you come here and you can see where the periodontal ligament was in this area, and you come over here and you look here, that's not normal, that's unhealed bone, all in those areas. And up here we don't have a very good picture because it's only 3D. This person has a problem, it's called earectomies. This should have been, earrings should have been taken off first. But then again, you can see in this area what we call normal is really just common. Up here you can still see where the tooth was extracted. Down here, this patient came to me a week after she had an exam. She was sick. She had a lot of gastrointestinal problems. She had lumps on both breasts. And down here the doctor said that was normal. And let's face it, anybody can see that that is not a healthy situation. This was a patient and my hygienist who had a lumpectomy, and she was part of one of the studies that I'm going to present today, which was my dissertation at Capital University. And she had a right breast lumpectomy, and we took all this stuff out. But just not normal. You can even see down here where the third molar was, and you can see the outline over here. This is 30 years before she had it. It should have healed by now, but we call that normal. This is a pretty cool thing. If you have a 3D, now let's see, this movie's not going to walk. This is crazy. Come on, guys. I don't know why. It worked great on the plane. It's supposed to go in fashion and go around. Well, what we're going to do is we're going to show you a 3D Galileos and the advantage of this machine other than its cost. This is a Sirona 3D imaging. Come on, guys. This is not an iCat. It is a 3D, what do you call it? It is a 3D cone beam technology. iCat's another brand. This is Sirona, who makes CEREC machines. The reason I bought this was to be able to not have a hassle with the state board, because when you look at things like this, you can take your viewer on any Windows compatible place, and I can come here, and now if I look at this screen down here that I'm showing you, I can see exactly where that little piece of mercury that I highlighted right there. And that will tone it, so now from this view I can see where it is in relationship to the cortical plate, and then I can do a surgery prior to even walking in there. I know exactly where that root tip or where the apical is or whatever, and I can go back and forth on that to get a different view. I can come down here, and anywhere in this I have a view of what's happening in that jaw. I can even go up to the TM joint, and down here where the crosshair goes, 5 millimeters distal, 5 millimeters mesial. And it will give you an excellent view. So if you don't have one of these in your office, which I don't see why most people would, you can send it to an imaging center, and if you're going to be doing a Nico lesion, or if you're even considering it, you have a very good outline, and you can see exactly where everything is, and you can do this on your own computer like I'm doing right now. The only thing that you can't do on your computer is implant alignment. That has to be done in the main computer. But if you can also take a look and look at radiology, and you can sit here and cut the brain, the skull in half, and you can look at this individual, and I'm going to tell you that this person has a breathing problem. Here's a hyoid bone, the epiglottis, but the tongue's taking up most of the space. And if anybody has had the pleasure of taking oral systemic balancing, the class given by Dr. Robson out in Tacoma, Washington, he explains the ill health from that. So the 3D gives you a perspective prior to going in. We had somebody that had something down in the third molar area that showed up, and I thought it was a root tip. And by the time we had imaged it, and I couldn't find that one, I'm sorry, the object was back here in the throat. So on a 3D picture, you could find it. On a two-plane picture, you'd be going after something you'd never find. So it's an excellent, excellent tool to be able to go through and utilize in your practice. That from Sharona and others is going to be $175,000 to $200,000. So, but we also, what I did to offset the course was hire a person who used to run an imaging center. She had retired because she didn't like her boss. And so we set up an imaging center, and we've got 5 oral surgeons and a bunch of orthodontists referring patients over. So now it's starting to pay for itself. But you got to get your directions right. So here we go. By understanding the structures of the tooth supporting components, one can understand why teeth play an important role in human health. And it's the periodontal ligament. Perio is around Donald's tooth, ligament holds bone to bone. Now I know this is very basic for those who have been in this for a long time, but I was asked to give this to somebody who's getting started. And I don't apologize because I have to remind myself of this every day. This part of the presentation, if you go to that front page, and if you want this so you can utilize the exact same slides, you email me and I'll send it to you through You Send It. So I have no problem sharing this with anybody, and you may use it. And you can just say that Dr. Mike let you use it, okay? The purpose of the PDL is to hold the tooth and jawbone, give you feeling without pain, and prevent bone growth. That's the killer. How many patients a year have their third molars taken out? Would you say 1 out of 10? 8 out of 10? Higher? At least 6 out of 10? How many oral surgeons go in there and clean out the periodontal ligament so it's clean? I see a head going like this. My head turns around 3 times. I wouldn't trust an oral surgeon to extract a tooth. By the way, my son is going through oral surgery right now at Yale. And I told him, you don't know how to pull a tooth. Boy, did he get mad at me. An infection in one part of the body, focal infection theory, states that it may cause complications in another. This is very true. Even traditional dentistry and medicine say that you have to be pre-medicated if you have a heart condition, if you have an artificial joint that now is only 6 months old. After that, you're supposed to be healed enough so it won't be a problem. Or if you have a kidney condition or some other condition that you need to be pre-medicated. So a source of infection in one part of a body may become a health interruption in a distant part of the body. Materials in the mouth may offer or affect the lining of the intestinal tract, muscles, joints, and other parts of the body. Think of what we put in there. Galvanic charges, amalgam, nickel. Oh my God, a number of kids that I have in braces now, we've had to take them off and get them desensitized to the nickel. Remaining PDL may interfere with a person's energy flow along the 5 acupuncture lines and impacted wisdom teeth. Can cause great problems. So when a tooth is extracted, either the periodontal ligament comes out or it stays within the bone. The remaining periodontal ligament within the jaw socket prevents bone growth, creating an environment for bacteria and viruses to live and heavy metals and pesticides to settle. Remember that picture where I pointed out where Jerry Bocuse showed where the turbulent area is for the blood to turn around? That's your third molar areas. When you have a periodontal ligament in there, it acts as a filter. It keeps all the crud. That crud is food for viruses and bacteria. To prevent infection from or conditions that are toxic from developing, the biological dentist will surgically remove 1 to 2 millimeters of bone within the socket. Therefore, you take out the remaining periodontal ligament. Gives you better healing. I can only think of, in the last 15 years, 2 dry sockets caused by smokers, and decrease the possibility of developing ischemic osteonecrosis in dry sockets. So root canal therapy is performed when the nerve has been exposed by trauma or vicarious lesions, a cavity or whatever. We know that the blood vessels are taken out of the organ. Remember, the tooth is an organ. What's an organ? It has its own blood supply, neurological supply, lymph supply, and performs a function. I had an argument with a physician. He says, teeth are teeth, they're not organs. I said, what does an organ do? And he looked at me and he just said, well, your liver's an organ. Yes, it's an organ. I said, what makes it an organ? And the guy just walked away. I'm a dumb dentist. I don't know anything, right? So anyway, what happens, consequently, the protein that existed in the dentinal tubules of the tooth will decompose and the toxins are forced into the periodontal ligament. Now at this point, I have a picture with the patient and I'm drawing this and I'm putting out a thing that says dentinal tubules are 30 microns. It's 100 degrees Fahrenheit. It is dark. It is moist. It's a piece of meat, protein, amino acids sitting there. How would you like to cook that for dinner? Think about it. It's becoming necrotic and spewing over. Now, I know the gentleman next door, my past instructors over at Capitol, I love these two guys. They're doing an ozone thing, and they'll tell you, hey, we're going to do a wonderful ozone root canal on this, and it's going to be great, and it's going to live forever and ever. What happens when you have a root canal? The tooth is dead. There's no pressure pushing out anymore. So that tooth can't keep a healthy balance going back and forth. So therefore, everything goes into the tooth. Even if you ozone it, now you got food sitting there because you can't clean out those canals. And it'll be okay for a while. And if you had an ALT, which isn't available anymore, if you had that and tested it 18, 20 months down, it's necrotic again. It's poison. It's toxic. So when you're trying to do these things, and everybody tells you, well, yeah, all you got to do is ozonate it. I use ozone every day in my practice. And I use it very effectively, and I can show you pictures of teeth that have been traumatized next to past extraction sites, clean them out, and reverse things that look like they needed a root canal. But use it appropriately. Root canals are dead. So you have to make decisions. Do nothing, further investigate with a cavitat study, homeopathic remedies, oxygen treatment, or surgical excision of the affected area, extraction of the tooth, whatever is needed. Warning, the American Dollar Association and many state dental boards do not approve of the removal of serviceable mercury amalgam fillings, healthy root canal teeth. What's healthy about a dead organ, by the way? And then, or hidden bone lesions from patients' jawbone, or recognize holistic dentistry as a specialty. Holistic dentistry is not a specialty. Remember that. Neither is TMJ specialists that are out there that say they're specialists at TMJ. That's not recognized. But the boards don't generally go crazy on that. Here are the 5 meridians, and this is in the slide presentation I'd send to you if you like. And what I do is I go into a very basic diagram, and then I go into this and I show people urogenital, the first one, anterior. That means nothing to a patient. But this does. I sit there a little while and I say, okay, here are your front teeth, here and here. And they will affect, depending on your model, if you are an ovary or a testy, if you have kidneys and adrenal glands are affected by this. By the way, your upper laterals or lower laterals, fibromyalgia, chronic fatigue. Just ask them. It's like a road map. Then I go into this again, but I go to this picture. Your liver and gallbladder is your major detox organs, and also structural, your hips and your knees. Then we go into the 3rd meridian, and I skip over that because people need pictures. Dentists can understand the numbers, pictures are better. Upper premolars, lower molars, large intestine, lungs, thymus. What's the thymus do? Educates your T cells to keep you healthy. And then, this is the one that got me because I had a root canal in number 3. I got rear-ended by a tow truck going 45 miles an hour, and my neck went from 18 inches to 24 inches in 20 days. And I also had kidney stones twice. If I ate anything, I should have been hooked up to a car because I had uncontrollable gas. It was terrible. And that root canal was taken out and all the things went away. all the things went away. Unfortunately, I had the root canal taken out after I had my thyroid removed that was totally healthy. And so when I see this, and I have women who walk in and they got a mouthful of mercury fillings, and I see root canals on these teeth here, I ask them if they have more fibrotic tissue in the breast on that side of the body, and 98% of the time it will be on that side of the body. It's a roadmap. If you sit down and learn this and talk to your patient, and you talk to them and say, here's your panel, let me tell you what I know. I haven't seen your health history yet. I went through, and I do this all week long, and people just sit there and they say, oh, I better get something else checked out because you got 90% of it right. Maybe I missed something. And here's the real killer. It's the third molars. How many of your older patients have heart problems, blood pressure problems? It's because it's controlled by your third molars. And people either have them impacted or they have dirty extraction sites that have never been cleaned and they're toxic. Also your small intestine where major digestion takes place. So there's a lot of truth in this. When you look in someone's mouth, you can see if it's healthy or unhealthy. And of course, we know that ALT is not out on the market due to some glitch. I don't know, did Dr. Haley speak at all? Okay, well, he sent out some emails on what happened there. Jerry is over in Houston. Talked to Bob Jones today. If you want to write down his phone number, I added it today. He is still in business. They're taking a few weeks off this month. I know that Terry's trying to donate his machine for research purposes, and this has been a heck of a wonderful income maker for our practice. The neat thing about it is you have to do everything right. You have to make sure you line everything up in a row. This is just another diagnostic tool. You don't base your treatment on this. It's based on clinical observation, patient complaints, what you see in x-rays, and then this will back it up or disprove it. I had a person come in 2 weeks ago wanting to have a cavitation surgery. We did a cavitat on it. The x-ray wasn't conclusive. The cavitat showed, don't touch it, it's healthy, it's fine. Leave it alone. So it doesn't always tell you to do a surgery. Why do we do things? Well, this is really why we do biological dentistry. Infections under the teeth, relationship between specific illnesses in teeth, root canals, cause of illness, toxicity of materials, biocompatibility to dental materials, electrogalvanic and ionic migration, TMJ, pain syndromes, and sleep disorders. That's holistic dentistry. Over here I have a list of nice books to read, and I would like to put a resource number 7 I should put down there, and the gentleman next door by the name of Clifford. Unbelievable resource. Other modalities of treating NECO, non-surgical. I used to use homeopathics. I used to put in ozone. I used to use the laser, and they are great adjuncts. But after I went through the protocols written out on how to do ozone clearing of third molars and have everything done, I charged $28 for ozone in the mouth. So if I did 1 site or 100 sites, it didn't matter. And I had people that we knew we had to do third molars. So I said, hey, these guys said it's going to clear it up. So I went in, I did their protocol, and we actually reversed some areas around some healthy teeth. But we went back and did the third molars. And I tested it with toxicity, and I tested it with Jerry Boco's histology. And they were 4s and 5s. The nice thing about the ozone, I see a head going, yeah, I agree with you. The nice thing about the ozone is that it did bring things together and made the surgery a lot easier. It doesn't cure anything. It makes it manageable. So which way do we go? You have to follow this sign. You have to follow that sign. And you got to keep going. So what I did when I was at Capital University a zillion years ago, my dissertation was to see if the cavitat was accurate. Detection of jaw lesions and osteolytic abnormalities using the cavitat, ultrasound imaging, a clinical study utilizing photo affinity labeling, which was Dr. Boyd Haley's work, and histological assessment to Jerry Boco. And then we did traditional radiographs, and then we went ahead and we did the imaging by the cavitat. And then what we did was we identified the ischemic osteonecrotic bone, and infection or abnormalities were surgically entered. We excised the samples, are tested by 2 independent laboratories, and the photo affinity went first, and then we took histology second, and that's important with our results, okay? Because the biopsies would tell us either confirm the accuracy of the cavitat or it didn't. It only turned out to be 99.6% accurate. How accurate are your x-rays? Anybody know? How accurate is an x-ray, Steve? 40 to 60%. That's how accurate. Focal infection theory, again, remember we said one part of the body affects another part of the body. And so the toxic substances found in ischemic osteocytes, root canal teeth, and other oral conditions may lead to systemic disease. Traditional dentistry does not recognize pathology associated with IO and toxic nature associated with root canal teeth. But if you look in the literature overseas, the schools there are now stating how toxic root canals are. And despite studies identifying the above conditions confirmed by biopsies. So there's a current lack of recognition of these lesions. There could be a possible improvement of recognizing these bone conditions with digital radiography, which we were just getting into in 2000, and since it may be enhanced with the computer imaging, offering multiple contrast grades and colors magnified in 3-dimensional imaging, which is what cavitat does. So the digital x-ray might not be enough. So this paper explores the company's claim that digital imaging enhances identifying the bone lesions, 3D multicolor imaging with 95% or more accuracy, confirmation of the claim with surgical obtained tissue samples, and 2 different types of biopsies to identify unhealthy sites. The person that paid for this was me. I and my patients paid to have the service done. At that time, I didn't charge for individual biopsies, which I do now, but I basically financed it and did it with fee-for-service patients. I lost money on the biopsies. All patients were referred by integrative health practitioners. I'm very lucky to live in the state of Arizona because we have a holistic board. And then we evaluated different conditions that they wanted us to do. Mercury, composite restorations, root canals, dental prosthesis, crown and bridge materials, and bone lesions. So this was my group. We had 8 people, the ages from 66 down to 37. That patient, 37, is still with me and doing really well. This was one of the patients here. And what we did is this is a cavitat image. You'll see them, and we're going to go in a little more detail here, as the upper right, upper left, lower right. And what happens is you have a machine that puts a certain sound wave out and a catcher on the opposite side. It comes through, it puts it into an image, and this image is the way I present it to the patient, because when you look at this, you don't get the concept of looking straight down. And this straight down here shows that there's a lack of density. And that's all it tells you. You need an x-ray to tell you if it's toxic or not, because what happens if that's the patient's sinus? Why do you want to do a surgery on a sinus? So you have to integrate your information. And so it talks about the piezo film and how it all comes together. Jerry Boco did a grading for it, and it was a standard accepted by the FDA. 0 is total green, and 3 and 4 are your high grades. And you can go into the details. I don't expect anybody to understand unless you study it. This is solid bone. This is just a little breakdown. It's nothing big. Grade 1. Grade 2 is also very little. Grade 3, now we're starting to see a breakdown of the durolaminas and cortical bone. And then stage 4, there's no bone there. Now that does not mean it's pathological. You have to be able to correlate that to an x-ray and see what you're looking at. Now if that image over here is up here and you see the sinus high, you know there's no bone density. And if you go to number 2, which is right here, you can see it's a root canal tooth. Root canal tooth is number 3. Root canal tooth is number 4. Oh, my goodness, number 5. No root canal. Bone density starts getting much better. So surgical sites were identified through digital panoramic radiographs. The cavitat study treatment plans were accepted, and we were able, you can take these tubes and turn them around and show them and match them. And so anesthesia, lay a flap, enter surgical sites, obtain biopsies, clean surgical sites, prepare for bone augmentation and suture. So out of 256 sites, we had, from the 8 patients times 32, we identified 193 healthy sites, 63 unhealthy sites, which is a 75-25% change. What we didn't know when we did this study was Bob Jones was doing a study on bisphosphonate patients for an FDA study that was not accepted very well by the American Dental Association because their site was 95%, 85 to 90% unhealthy and 10 to 15% healthy sites. So therefore, there was a little what we call significant difference between the two. And that's why the company has been in litigation ever since they tried to get this approved. The frequency of sites, posterior teeth, your 3 major molars are going to be 86%, premolars are about 11%, canines are usually less than 1% and 3% in the anterior area is what we found in my study. Wes Shanklin had his studies about 6% here. He had more root canals on his front teeth. And when we did the biopsies, we found that most of them were ischemic osteonecrosis. So I called them ions. 30 were out of the 63, almost half. Then you had osteoporotic marrow, periapical granulomas. Now this is the, how do you get viable bone? When I went back and I looked at the ALT scores, these were over 90% toxic. The body is a wonderful thing. It walls off toxins. So when I got the sample for ALT, there was nothing left to give to Dr. Bocaux. You can't send an empty bottle for a biopsy. How much time? 1 minute? Okay. So what happens is we had to send the next bone. So the study had flaws. We won't go through all those wonderful flaws. Prevent positive false images. Take a thorough health history review. Reverse of the cavitat images for few imaging so you can turn them around. Compare results with both diagnostic tools, the x-rays. And each patient had multiple sites. All sites confirmed by biopsies. Toxicity was 100% and histology was 90%. And so what does it tell us? There's no direct correlation between the number of surgical sites, amount of enzyme inhibition, percentage rates to patients. 6 months after surgery, every patient reported an improvement of health. Cavitat is safe and effective. So basically what we wanted to see was a new technology, but down here, Nico lesions do exist. That was the whole purpose of that. We're going to take a little break. We're going to go through surgeries, and we're going to go through how to set it up and all that. So when you do it, you go through some very specific sets. So take a break. We'll see you back in 1/2 hour. I'll take questions.